I am Dr. Lawrence Smith, Dean of the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Thank you for tuning in to Well Said. In a culture of community, scholarship, and innovation, the Zucker School of Medicine is dedicated to transforming students into doctors who will improve healthcare, inspire change, and better the lives of the people they serve. It is why we are pleased to collaborate with WRHU Radio Hofstra University to bring you a program committed to sharing expert discussion and insight on health and wellness topics important to you. Join us today and each week for a recommended dose of Well Said with your host, Dr. Ira Nash.
Hello, I'm Dr. Ira Nash. Welcome to Well Said. In previous episodes, we've discussed specific conditions that can affect your heart, like atrial fibrillation, or even how heart health differs in men and women. Today's episode will focus on implantable cardiac pacemakers, sophisticated electronic devices that are widely used to treat a variety of conditions. My guest is my colleague, Dr. Jason Chinitz. Dr. Chinitz is the Director of Cardiac Electrophysiology at South Shore University Hospital, and he's an Associate Professor of Cardiology at the Donald and Barbara Zucker School of Medicine. Jason, welcome to Well Said.
Hi, Ira. Thank you very much for having me. Honored to be here.
So how are you doing these days? It's been kind of a wild ride over the last year.
It has been a crazy year, but we're doing very well. Things are back to our normal speeds in the cardiology and electrophysiology world, and South Shore University Hospital is busier than ever. So we've been staying busy and doing good work.
All right, well, I'm glad to hear that. So we have a lot to talk about today. So let's start at the beginning, or with the very basics at least. What is a cardiac pacemaker, and how long have these things been around?
Sure. So a pacemaker is a device that is meant to treat slow heart rates. So typically it's done with a wire that goes into the heart and keeps a heart rate elevated over whatever it's set to do. We've been using pacemakers for many decades. In fact, the first fully implantable pacemaker was implanted around 1958. And starting in the 1960s, they really gained traction. And the technology has come a long way, so that they've gotten smaller and more accommodating to patients along the way.
You said it's a device that has a wire that goes into the heart. Let's try to be a little bit more specific about how these things actually work. So there are two pieces to this, right?
Sure. So the heart is an electrical organ. In addition to being a muscle that pumps blood throughout the body, it requires an electrical impulse to create a heartbeat. And it's not just a rate, but there's a specific rhythm to the heart. And when the heart rhythm goes out of whack, people have arrhythmias. And when the heart rates get too slow, they have to be fixed. And a pacemaker is how we can overcome slow heart rates and keep a patient's heart beating at an appropriate rate. So it's done with a pacemaker generator, which has a battery, and it's a little device that's typically these days the size of, say, a silver dollar. And that gets implanted under the skin in the chest, and then a wire goes from that generator through the blood vessels and gets screwed into the heart muscle itself. So that wire is able to sense the electrical conduction that's going on in the heart and deliver a stimulus to tell the heart to pace whenever that's appropriate.
So that stimulus is actually kind of like a tiny little shock, right?
It's like an impulse. We try not to use the word shock. First of all, it's a painless impulse. Patients don't feel that generally with pacemakers. And also it's important to distinguish a pacemaker from a defibrillator, which is a similar structure but a completely different purpose. And a defibrillator is a device that will give patients shocks to treat very unstable heart rhythms. That's more like defibrillation or shock that one would see on TV.
The defibrillator is kind of like the internal version of what you see in those TV shows about emergency rooms and hospitals where somebody puts the paddles on the chest and the patient jumps off the bed. But that's not what we're talking about here.
And that's not what we're talking about. Pacemakers are not necessarily defibrillators. It does get confusing because defibrillators will also work as pacemakers. So patients who have a defibrillator will often say, I have a pacemaker as well. But from what we're talking about here, pacemakers, they do not shock you, and they're different than defibrillators.
Okay, but that little impulse that you're talking about is a tiny little electrical impulse, and that's why these things need a battery, right?
Battery. That's exactly right. It's an electrical impulse that is painless, and it runs on a battery. And these generators, the boxes that I told you get attached to the wires and placed under skin, have batteries that typically last anywhere between 5 and 15 years. We try to say we expect people to get about 10 years out of each pacemaker generator.
Yeah, so we're going to come back to the longevity of these things in a minute, but I just want to go back to what you said about these things being implanted, the generator or the thing that's the size of a silver dollar under the skin, and then the wire gets screwed into the heart. So how do these things actually get implanted? What's the procedure like to insert a pacemaker?
It starts with a little incision that goes kind of near the shoulder in the patient, in the chest. Now, if the patient is right-handed, we'll typically implant the pacemaker on the left side of the chest. For some patients who are left-handed or have other reasons why we shouldn't use the left side, it can be implanted on the right side. But it's an incision that's typically about 3 or 4 centimeters just below the shoulder and the left chest. We make a little pocket, which is a little space to put that pacemaker generator under the skin. That's not in the chest, but it's really under the skin, above the chest muscles. And then we're able to get a wire to go underneath the skin through the muscles into the blood vessels. And as all the blood vessels run into the heart, the wire is able to go down through the blood vessels into the heart. We can put these wires in specific spots in the heart. So typically, at a minimum, one of the wires goes into the right ventricle, one of the bottom chambers responsible for pumping blood to the lungs and the body. And then we can put additional wires through the same mechanism into other spots, such as the top of the heart. So by putting in more than one wire, we're able to create more of a normal conduction in the heart. We can recreate the physiologic conditions of the heart pacing or beating with the top chamber first and the bottom chamber following it.
So it kind of mimics the more natural occurrence of these electrical impulses in the heart.
We try to do that. We try to recreate the normal wiring. In fact, what I often tell patients is that when the wiring in your heart starts to get older and starts to work too slowly to function, we have to replace the wiring. And it's very much like replacing the wiring of an electrical system in your house. When it's broke, we have to put in new wires, and we try to make them work as normally as possible.
And you said that these wires actually are doing kind of double duty. They're sensing what the heart is doing, and then they're also delivering these impulses. Is that correct?
Yeah, that's right. In order for it to function normally, it has to know when the heart is beating on its own and when it should overcome it when it's not beating appropriately. So there's a lot of complicated physics that go into it, but it does need to sense and it needs to pace, and the wires can have problems like any other electrical system.
So it sounds like these things are kind of pretty smart in that they operate in such a way not to interfere with the normal beating of the heart, but to kind of augment it when the normal beating is not sufficient.
Yeah, that's right. We've learned over the years that while pacing is necessary for many patients with slow heart rates, it's not ideal. In fact, if patients don't need pacing support, it's better to let their own heart do its intrinsic thing and beat how it wants to. So we try to minimize the amount of pacing that the pacemaker does to what is only necessary. So that sensing is really important. If the pacemaker senses that the patient's own heartbeat is beating, it should not pace. It should withhold therapy and pace only when necessary.
So you mentioned that these are used when people's heart rates get too slow, or, as you put it, when their native wiring is not in such great shape anymore. Could you be a little bit more specific about what kinds of heart conditions or circumstances would lead a cardiologist or an electrophysiologist like yourself to recommend a pacemaker?
It generally is for when heart rates are too slow. And too slow is not a specific number, but generally a slow heart rate that is associated with symptoms, meaning there are various different electrical problems that can cause slow heart rates. Most of them are not dangerous unless the patient's having symptoms. So if someone comes to me and their heart rate is 50 and they feel great and they're a well-trained athlete, they don't need a pacemaker. But if their heart rate is 50 or 40 or 30 and they're feeling tired and lightheaded, that's typically a sign that they will need a pacemaker. So again, there are different types of electrical problems that may make this more of an urgent problem that needs to be fixed, but symptoms are really important in us deciding when somebody needs a pacemaker to help them. There are some other indications for pacemakers besides that, but that's the main one. I will tell you that there's one other indication that's really an important thing in cardiovascular care, and that's something called a resynchronization pacemaker. Not to make it confusing, but there's some patients who have heart failure and have one of the reasons why their heart's not functioning well is because the electrical system is insufficient, so that one side of the heart doesn't beat on time with the other, and the heart beats inefficiently. With a pacemaker, a special type of pacemaker, we can put wires on both sides of the heart, the right side and the left side, to kind of restore this synchronous contraction of the heart, and that can dramatically help the heart function better in the right patients. So there are these other interesting indications for pacemakers that are important as well. But like I said, the primary reason are for slow heart rates that are making patients uncomfortable.
And just to be clear, for the folks who are getting it for the more common reason of having a slow heart rate, their heart rate doesn't have to be slow all the time, right? These are sometimes people have episodes where their hearts get very slow, or they can have symptoms just on an episodic basis, and a pacemaker may still be a good idea for those folks.
Yeah, absolutely. So there are people who have chronically slow heart rates, and then there are people who have periods of slow heart rates, and they can be what we call pauses, where the heart suddenly stops for a few seconds. And that can be a cause of passing out or syncope. And sometimes we often don't know why people are passing out, but if we're able to monitor them long enough, we may see that there are these periods of very slow heart rates or pauses that causes them to get dizzy and pass out. And in those cases, a pacemaker can be really important to help them. And again, the pacemaker in those cases wouldn't be working all the time because most of the time their heart rates are okay, but it would then kick in when needed and can prevent them from passing out.
And that gets back to what we were talking about before, right? That these things are really quite sophisticated and sort of are mostly in standby mode until they're needed, and then instantaneously can start up and do what they need to do.
That's right. So they can be very sophisticated, but for most patients, they need something that does exactly what you just described. Wait until the heart rate gets slow and then kick in and pace when needed. So
you described the procedure by which these are implanted. Can you give us a sense of how risky it is to get a pacemaker implanted? What's the downside of having one of these devices?
Well, like all procedures, there are risks, and it's a small surgical procedure to implant it. Typically, we tell patients there's about a 1 to 2% risk of complications from the implant procedure. Those can be things like bleeding or infection at the implant site. There's very rare risks of injury to the lungs or the heart muscle when we're putting these wires in. Again, those risks are, in general, implant less than 1 or 2%. But that's not it. Once these patients get these devices in, it is typically something that they're going to have the rest of their life. And there are subsequent risks of problems happening in the future. Infection is certainly one of them that can come up later. But it's an adjustment for patients to live with these. And the implant procedure itself, while not without any risk, is generally considered relatively low risk.
So let's talk about some of those adjustments that you said that people need to make. I guess you talked about one already, implying that you like to put it on the side opposite their dominant hand. Is that because it kind of gets in the way, or is there something more to it than that?
Yeah, in reality, it doesn't. It should not get in the way of any of their normal lifestyle activities. There is a restriction after the implant where we tell patients to take it easy with that arm after implant. So, for example, if we put it on the left side, I'll generally tell patients to avoid heavy activity with their left arm for the first month. And that specifically means not lifting heavy things more than 10, 15 pounds, not stretching that left arm. It's mostly so that nothing pulls at the incision and allows everything to heal well. So there are minor limitations like that, which can be a bigger problem if it's on a patient's dominant hand, and we try to keep it away from that. But apart from that early post-operative limitations, it should not get in the way. And some patients just prefer not to have a device on their dominant side, but if it was on that dominant side, it wouldn't really slow them down.
And those kind of restrictions that you're talking about are not permanent, right? Once this is fully healed, they can go back to the gym, play golf, exercise, swim, do whatever they want?
Yeah, that's right. So I tell patients after about 6 weeks or so, they have no limitations at all. People are frequently excited to go back to have their golf swing, and I tell them it's not going to be limited, but they have to just take it easy early after implant.
And sadly, it probably doesn't help their golf swing either, right?
No miracles here.
No miracles, right? Let's go back to the other thing that you mentioned before, which is the longevity of these things. We're saying that they have a battery because they have to kind of fuel that little electronic brain that's doing all of the sensing and pacing, and then they have to deliver these impulses to stimulate the heart to beat. Are these batteries rechargeable?
That would be nice. No, they're not rechargeable. They are batteries that are embedded within the device. They're not things that we can remove. I mean, we never take the battery out. When we do battery changes or generator changes, we're changing the entire device itself and attaching a new device to the wires that are implanted. Like I said, we generally get battery life's close to 10 years on these devices, but of course it depends on the type of device and how often the patients are using it and the electrical parameters of the device itself. So it can be quite variable. There are not rechargeable options, but there have been a lot of discussion about what the future of these batteries hold. Is rechargeable is that a possibility? It certainly probably will be, but that has a lot of implications and questions as well. How often would you have to recharge these batteries? What happens if a patient forgets or can't do it or is incapacitated? A lot of difficulties with that decision. So right now we use typical batteries. I believe that they're mostly lithium-type ion batteries, and we monitor the devices regularly. So every patient who has a pacemaker is followed in a pacemaker clinic where we look for any type of device malfunction, and we monitor the battery life. And as the battery life is getting low, we call it the replacement interval, the elective replacement interval. When we believe that when the device is getting to less than 3 months or so left in battery life, that's when we make plans to change it.
Tell our listeners a little bit more about how that monitoring is done.
There is a way that we can check these devices in person. Basically, we put a little magnet on top of the patient's skin, and we're able to download all the information we need from the pacemaker. And we can also do reprogramming through that method as well. So when patients come to the office, we can check their pacemakers and get all the information that we need and make any adjustments. When patients are home, we also have the ability to monitor them. Most patients are enrolled in what we call remote monitoring for pacemakers, and they have a little device that they plug in at home. Usually we tell them near their bed, and when they're near that device, it can sync up wirelessly with the pacemaker, and that will transmit information. And everybody's records are carried on these online databases, and with these remote monitoring, things get updated, and if there are any malfunctions or concerning arrhythmias that are detected this way, we as the clinicians will get alerts, and then we can be in touch with patients. So that technology has changed a lot, but these days we try to keep all patients with pacemakers on remote monitoring because we think that's the best way to keep a close eye on them and react to anything that's wrong. It also it allows patients to visit the doctor's office less if they don't need to come in to have it checked. And that was particularly critical over the last year during COVID. We were able to keep close tabs on all these patients without them coming to the office.
You mentioned that these devices that you can apply over the skin in the office to kind of read what's going on in the pacemaker also allow you to change the behavior of the pacemaker. What kinds of things might you be adjusting?
So we may want to change the rate that it's pacing at. So, for example, if a patient's heart rate is 60, but we think that they would feel better with a higher heart rate, that's easily programmable. We can change the pacing mode. So it paces from the top chamber, the bottom chamber, or synchronously together. And then there's various little technical changes that we can make to optimize the functioning that are kind of detailed nuance of it. But we want to make sure that everything's functioning as optimally as possible, that the pacing is done when it's appropriate and not being done when it's not necessary.
You know, as you were talking about these remote monitors and the ability to communicate with the pacemaker wirelessly, the first thing that came to mind was all the stuff that's been in the news lately about computer hacking. And I wonder if some of our listeners might be a little nervous about the fact that their pacemaker is accessible to a wireless device that can change how it functions. Can you address that concern?
Well, there was an episode of this TV series Homeland once.
Yes, I saw it.
Yes. The vice president had a defibrillator, and someone was able to hack into it,
Right.
and that started a lot of concern over just that concern that you mentioned. So it turns out that though theoretically possible, there has never been any type of report of actual hacking being done of a pacemaker, and it would require even in the theoretical possibilities of how it can be done, it can't be done remotely. It is possible that somebody could be very close to the programmer and get this information and do it. So because of this theoretical concern, the companies who make these devices have gone to great lengths to try to make them safer for this new environment. And there have been new software updates that a lot of these devices have to try to prevent that possibility. So I certainly understand that that would be a concern of people, particularly in this day and age, but we believe that they're pretty safe.
What are some of the other concerns that people routinely voice to you when you are talking to them about their potential need for a pacemaker?
They're concerned about the limitations, if they can do everything that they used to be able to do, if they can, like I said, play golf and be active. And for the most part, we can be really reassuring their life should not change. Most patients who are getting pacemakers are going to feel better after they get the pacemaker. So we try to be encouraging that not only is their life not going to get worse, but hopefully they're going to be able to do more than they ever could before. I think some patients are concerned about the aesthetics of a pacemaker, and we have different options, but for most patients, once it's implanted, it's not something that interferes with their life. Probably worthwhile bringing up another anecdote that just earlier this year, somebody from the New York Yankees needed a pacemaker. And
yes,
there was a lot of
Aaron Boone.
That's right. The manager needed a pacemaker during spring training, and unfortunately, he did not come back to New York, Long Island for his pacemaker. But he got it during spring training, and 2 days later, he was back on the field, and didn't look any different. So we hope that patients don't really have any major limitations. Most of the time, that they certainly don't.
You mentioned the aesthetics, and that's because in people who are relatively thin anyway, you can actually see this small lump under the skin, right, where the generator is placed.
Yeah, so traditionally these devices go right underneath the skin, and like you said, in a thin person, it will be visible. And as these devices get more complicated and we start talking about defibrillators and resynchronization therapy devices, they get bigger and bigger, and they could show under the skin. We have ways to get around that. When we anticipate that will be a problem, we can try to put them under the muscle, and I'm sure we'll talk soon about some newer types of pacemakers that can avoid that completely, but that can be a concern about the aesthetics.
Yeah. I know another concern that people raise or is out there in kind of the public perception about pacemakers is concern about metal detectors and home appliances. Could you address those concerns?
Sure. They're generally not real concerns. So household appliances like microwaves, cell phones are generally not a problem. Now, what you really have to be careful with when you have a device is a magnetic field. So when there are strong electrical currents that can create a magnetic field, and the patient with a pacemaker is within that electrical field, that can sometimes disable a pacemaker or make it function erroneously. That's not going to happen with routine household appliances. It potentially could happen with things like arc welding, or these large industrial motors sometimes can do it. The other thing is magnetic fields can sometimes come from unusual places. So while cell phones have traditionally not been a problem, the newest generation of the iPhone has a little magnet in it. And there have been reports of when patients have these new iPhones in their chest pocket right over their pacemaker, that could maybe deactivate one of these devices. So you should always still be careful. Going through a metal detector at an airport is probably not going to disable it, but it's always important that a patient tells security that they have a pacemaker, and typically their appropriate precautions are taken. That being said, as long as nobody's hanging out under the magnetic field, probably nothing terrible is going to happen.
Are these things large enough to actually kind of trip the metal detector? Like if you forget and you walk through, are alarms going to go off?
Certainly could. I think it depends on what type of device they have and what type of metal detector. But they are made of metal, and if that's all someone's looking for, they will find it. Again, it takes a little bit more than that screen to cause any problems with the pacemaker, but it may go off.
Right. So best, as you say, to alert the person operating the metal detector that you have a pacemaker if you're going to walk through it.
Yeah, that's right. And they usually have signs in the airports telling patients if you have a pacemaker to let them know, and they'll take you around.
You gave a little bit of a tease about where the field may be going. So why don't you give our listeners a sense of what's under development, what are you working on, what's new?
Like I told you, the first pacemaker was implanted around 1958, 1960, and for the first 50 years, it was slow progress. The devices got smaller, and some more features were added, but it was nothing too dramatic. In the last 5 to 10 years, it's gotten a lot sexier, and there are a lot. There's new developments in pacemakers that are kind of changing the way that we look at this. One of the biggest changes is the development of what are called leadless pacemakers. A leadless pacemaker is an entirely self-contained pacemaker that can be put inside a patient's heart without having any device under the skin or any wires running anywhere.
So, Jason, tell me again how large these things are?
I usually describe them the size of a battery, and they're probably similar to a AAA battery, maybe a little bit smaller than that. But the volume of it is described as 1 cc. So this has the potential to revolutionize pacing. Because maybe one day we won't need these devices that we just spent the last half hour discussing that go under the skin with wires that go into the heart.
Yeah.
And maybe the entire thing could be put in these little devices that get implanted inside the heart. We currently have these leadless pacemakers. They're in their kind of first or second generation, and they're used for many patients who need kind of simple pacing or for patients who can't get implanted with the traditional pacing. But these are really exciting, and they have the potential to dramatically reduce complications related to pacemakers, and it's a totally different experience for the patient who no longer would have any reminder that they even have a pacemaker. So we're excited about those. We implant them a lot here in Northwell Health for patients who can use them and when it's appropriate. And we're looking forward to the next generations of these leadless pacemakers that will allow us to do things like pacing multiple chambers together, resynchronizing the heart with these type of devices.
Say again how large or small these things are. You said AA battery, but AA battery seems kind of big to me.
They're about 1 cc. It is a little smaller than a AA battery, but not much, maybe 3/4 the size. It's like a little bullet, and we implant them inside the heart in the right ventricle with a catheter that introduced through the vein in the groin. So just like when we do ablations or catheterizations and we put these catheters through the blood vessels in the groin, we can put an entire pacemaker that's collapsed inside a small catheter inside the heart, and we kind of release it through this catheter and then take the catheter out of the body, and the patient's left with these little devices in their heart. Yes, it's not microscopic. There are the size of a small battery because they have the entire battery contained, but they fit easily within the heart, and you could even fit a couple in there if you needed to.
So where can our listeners go to learn more about the current and future iterations of pacemakers?
Well, I invite you to come meet with your cardiologist or your local electrophysiologist at Northwell, and we'll show you all the options that we have. There certainly is a lot of information online that one can get, and if you're interested specifically in the leadless pacemakers, I would look that up. The current generation that we use mostly is called a Micra leadless pacemaker, to imply how small it is. And I think the best way is to talk to your doctor and get as much information as you can.
All right. Well, that's great. Well, thank you so much for joining us today. My guest has been Dr. Jason Chinitz, the Director of Cardiac Electrophysiology at South Shore University Hospital and an Associate Professor of Cardiology at the Donald and Barbara Zucker School of Medicine. Jason, thank you so much.
All right. Thanks so much for having me.
For more information about this program and to find past episodes, please visit sites.hofstra.edu/wellsaid. You can also subscribe to our free podcast available on Apple Podcasts, Stitcher, or wherever you get your podcasts. Our listeners are welcome to send comments, suggestions, and questions to wellsaid@hofstra.edu. Until next time, I'm Dr. Ira Nash, and that's Well Said.